Michaela?
Yes, ma'am, I'm here.
Can you do 8:30 tomorrow morning?
Yes, that sounds good.
Okay. And I have your Skype name, don't I? So I can just Skype you and then we can sort out your schedule.
Yes.
Okay. Alrighty. 8:30 in the morning. Let me write myself a note here. Okie dokie. All right. So we're going to continue with the cardiovascular system. Does anybody have any questions from the video lecture on Friday? I'll just move on from there. Okay. Good. All right, and I forgot a battery for my remote mouse again, so I'm going to have to be running backwards and forwards here. All right, so
What PowerPoint are we in right now?
let me have a look. I think the one that's up is the chapter 6. Look here. See which one I've got up.
But we don't have it, right, on Blackboard, or do we?
Should be. Just won't look like this because you'll have probably the plain version. Let me see here. Oh, you don't have it because I forgot to open it. That's not good, is it? I think it's this one. Let me see. Okay, that's the boring one. Let me open up the, sorry about that. Thank you, Neri, for catching me.
Thank you.
Okay, we've got a couple of slides on the 6A old version and then we'll go into the 6B old version. Go. All right, so we've looked at the heart, now we've got to look at the other part of the system, which is all the arteries and veins and how the blood is moved around the body. All right, so one of the things we need to understand is blood flow through the system. And blood flow follows a physical law. So if you've done some physics or if you did physics in high school, I'm not sure, do you guys do physics in high school? I'm not sure. Then you might recognize this rule, this law, that gases and liquids move from an area of high pressure to an area of low pressure. And actually it's not just gases and liquids. When we look at ions moving back and forwards across the membrane, they do the same thing. They move from an area of high pressure to an area of low pressure. Okay? So that means then that the rate of flow, right, so the speed or the amount of flow is also proportional to the pressure difference between two ends of a vessel. Okay? So the blood flow and the rate of flow are both connected to this idea of change in pressure across the system. Right? So blood flow is the change in pressure divided by the resistance to the flow. Right? So if we increase the difference in pressure between point A and point B, then we increase the flow. So we could do that, for example, by increasing the force of contraction of the heart. And that's what we see happen with training, right? The heart gets stronger and therefore it can contract more strongly. Right? We can also increase blood flow by decreasing the resistance to the flow. Right? So if I can increase the radius of the vessel that the blood has to flow through, then we can increase how much blood is flowing. Right? So there's a very large effect with changing the radius because we have central nervous system control over increasing and decreasing the radius of the blood vessels. Right? When we look at exercise then, both of these two mechanisms occur when we exercise simultaneously, and so we get much larger blood flow around the system when we're exercising, which is obviously a big benefit because we need the oxygen and we need the nutrients, we need the glucose and the fat that are being carried by the bloodstream. Right? We could lengthen the vessel, or we could, we would see changes if we change the viscosity. So when we're dehydrated, we increase the resistance to flow, so that's not a good thing. That's why we see some drop, one of the reasons why we see drop in performance with dehydration. All right. One of the diseases that we talked about Friday, a couple of the diseases we talked about on Friday, discussed arterio and atherosclerosis, right? And so what happens with those, you can see this is a very simple diagram of what's occurring there. We get plaque buildup within the artery, and so as the plaque builds up on the walls of the artery, effectively what's happening is it's narrowing the radius of the space for the blood to flow through. So people who have plaque buildup have higher blood pressures because they're trying to force blood through this much smaller, narrow space. Does that make sense? So particularly if you've got those in your coronary arteries, then they are a big precursor to a heart attack. Right? So controlling the radius also allows us to direct blood flow where we want it to different areas of the body. So we'll see later on that we can direct blood flow to the stomach when we've had a meal, or we can direct blood flow to our muscles when we're trying to exercise. I'm trying to play with the mouse that isn't there. Okay, so last week in lab we talked about collecting blood pressure. I put some film clips up for you to show you how we would have collected blood pressure if we were here. Right? And some of the information that pertains to that, so we've got these categories that it's important to understand, because if you're going to be setting a training program for someone and they tell you that they've got some hypertension, it's really important to know where they lie on the continuum. All right? So if we have normal blood pressure, then our systolic is going to be less than 120 millimeters of mercury, and our diastolic is going to be less than 80 millimeters of mercury. All right? If we're high normal, which in our lab book is called pre-hypertensive, I like it being called pre-hypertensive, because high normal is a description that if I wanted to stick my head in a bucket and ignore the problem, there's a normal in there, right? So personally, I like the label pre-hypertensive for this second group. 120 to 139 and 80 to 89 on the diastolic. Remember that we only have to indicate chronic high numbers in one of the two pressures to be diagnosed as hypertensive. So it doesn't have to be both of them, all right? But it does have to be a chronic picture, not just a one-off. And then we've got stage 1 hypertension and stage 2 hypertension, all right? Someone who is stage 2 is unlikely to get doctors sign off to come and train with you, right? Because this is pretty dangerous at this point. So they're going to be trying to bring that blood pressure down with medication, because they could pop up an artery in the brain or have a heart attack. Literally, they're a walking heart attack at this point. So they're not, in my experience, this group of people are not likely to be sent to you for an exercise program until they're lower down the continuum.
Hey doctor, well I got one quick question.
Sure.
For the people who are trying to get eligible for like the bariatric surgery, most commonly what range or like category here would they be in? Obviously, you know, we're not normal, but those kind of candidates wanting that surgery, what kind of blood pressure do you think they have because of their size?
Phew. I would think, I mean, they might be stage 2. I don't know enough about clinical practice to know if they would be approved for surgery if they were stage 2. Because I would have thought that that would be pretty risky to put them under at that level. So there's a part of my brain that says they're likely to be a stage 1 if they're approved. But on the other hand, if they're obese enough to be a candidate for bariatric surgery, then you would imagine that they've got pretty high blood pressure. But I can't honestly answer your question accurately, Kayla, although it's a really interesting question. I just know that every time my mum had surgery, they were really keen on keeping an eye on her blood pressure, but she was stage 1. I don't, to my knowledge, she never crossed over into stage 2. You could possibly look at the American Heart Association website. There might be some more information there. Where else?
So when doctors refuse to give them a surgery, it is, or you could say blood pressure is one of those reasons why they won't put them under anesthesia, right? Not just because of their size.
I think so, yes. Because the problem is, you're under and you're lying down, but they're going to be stressing your body, right? And they've got to be able to get an air tube in, and they've got to monitor your pressure and your heart rate and your breathing rate. And so, yeah, to my knowledge, blood pressure would be an issue. I guess they're going to have to weigh up all the problems, right? And maybe having stage 2 hypertension is the least of their worries, right? And the decision could be made to have the surgery, but I guess it would depend on what the surgery is. I mean, if it's surgery for cancer, for example, then I think this is not going to stop them doing the surgery, probably, depending on the cancer and the level of the cancer, I guess.
Okay, that sounds good. I'm sorry to get off on that tangent. I was just wondering.
No, I like that tangent. It's interesting. I wish I had a more accurate answer for you. Where was I? Okay, yes. So when we increase cardiac output, right, so when we do exercise, then essentially what that means is the heart is pushing out more blood into the same physical area, right? So exercise increases blood pressure for that reason, right? And depending whether that exercise is aerobic or resistance, we see increases to a different level. Resistance exercise increases blood pressure dramatically, right? But then doing the exercise, particularly aerobic work, increases capacitance of the arteries. So what that capacitance is the fancy word for stretching, right? So what that means is that when I do regular aerobic work, we increase the elasticity, the stretchiness of the arteries. And so when I push that extra fluid through, the arteries can give a little bit more to allow for that extra blood flow. And so then we see a little decrease in the blood pressure for the same amount of work, right? That's how exercise can help to improve hypertension in these two levels, right? As I said, this level, this stage 2, is unlikely to get sent to you for help because they're about to drop dead. So they're not going to let you increase their blood pressure by exercising them, right? Okay, so I mentioned that there were some changes in blood pressure, so let's have a look here. If we are looking at an acute situation, so I get up and I go and exercise, okay? Then with aerobic work, we see an increase in systolic pressure up to maybe 250 millimeters of mercury from our 120, right? So somewhere in that range when we just get up and go do some aerobic work. We would not expect to see change in the diastolic, in the lower number. I mean, it'll flicker around a little bit, but we don't see real change. So they can actually use that for a diagnostic tool in a clinic or in an exercise science program, right? If they put you on the treadmill and they've got you walking or jogging, your systolic pressure should be going up and your diastolic pressure should be staying relatively level. If your diastolic pressure starts going up, they're going to cancel the test and they're going to send you for further investigation because that should not be happening, right? So that's indicative of a problem. If we just get up and go to the gym and we do some weight training, then what we get is very large increases in both systolic and diastolic in relation to the amount of weight that we're lifting. But they have seen, it's been documented, 320 over 250. Right? So that's a huge increase. So then we have to take that information and think, all right, well then, if I have someone who is overweight, right, they've been signed, or obese, they've been signed off by the doctor to come and get a physical activity program, to get a prescription so that they can do, follow a good program that's well adapted to them, then do I want to give them resistance work initially, right? Because resistance work severely increases blood pressure. So if they've already got high blood pressure and they're being sent to you for a program, you've got to think about, do I want to include resistance work? Right? It might depend how high their blood pressure is, right? Or it might depend how urgent the situation is, right? If the doctor says, okay, come back in 6 months, go away, get this exercise program going, be physically active, change your diet, come back in 6 months, then maybe I might do some body weight stuff or bands, right? For the first couple of weeks before I introduced any real weights. Or I might not do anything for the first couple of weeks. I might concentrate on, if they're at the higher end of their blood pressures, then I might concentrate on that aerobic work that I know is going to increase capacitance of the arteries and help bring their blood pressure down. Right? Over time, if we keep doing our physical activity, then we've got a situation where we see both aerobic and resistance work reduce resting blood pressure. So that's the one that we talked about last week. We've got to take that early in the morning. We don't really want to have dashed in from training and then take our blood pressure because it's going to be all skewed, right? So for normotensive, so for that normal range, and moderately hypertensive, so the pre-hypertensive and the lower half of the stage 1 hypertensive, we see reductions in resting blood pressure with training. Not huge, right? Probably less than 10 millimeters of mercury, takes a lot of time. Our submax blood pressures are reduced, so when I'm exercising, my blood pressure doesn't go so high, right? So that's good. That's a great adaptation, okay? And as I said, the good thing about aerobic work is that it increases the capacitance, makes the arteries more stretchy, which keeps them healthy, right? We don't want hardening of the arteries, because hardening of the arteries can be linked to the plaque buildup that's in there. If the plaque starts to go stiff and it's attached to the artery wall, then the artery can't move at all, right? What am I doing? Okay, hold on, we need to switch slides. Okay, so we understand how the blood mechanically can flow through the system, right? Because it's going to go from an area of high pressure when it's ejected from the left ventricle through the valve into the aorta. The aorta is the highest pressure in the whole system. And then it's going to flow around the system, and as it's coming back to the right aorta, in those veins, it's the lowest pressure in the system. Okay? So we've got the blood moving around the body, and it's going to be providing oxygen and nutrients to organs, tissues, etc. All right? So how do we transport the oxygen, since for us as movement people, that's one of the key items that we need to be able to move around the body in order to make ATP for exercise, right? So we rely on our red blood cells. Our red blood cells contain a molecule called hemoglobin, which contains iron, okay? And hemoglobin can transport oxygen, so it's like the bus system in the blood for the oxygen molecule. Okay? As long as there's iron present, so we'll come back to what happens when iron isn't present in a while. So the more hemoglobin we have, i.e. the more red blood cells we have, the better we are able to move oxygen around the body. Okay? So when we do aerobic training, after time, right, we're looking at a chronic effect, not on a day, okay? A training effect, we see an increase in plasma volume, and we see an increase in red blood cell count, right? So endurance athletes have much higher blood volumes and red blood cell counts than anaerobic or sedentary people, all right? Because the body's adapting for oxygen delivery. All right? Remember, adaptation's typically positive. We're going to adapt in a way that allows us to do the job more effectively. Okay? In adults, red blood cells are produced in bone marrow of long bones. So sometimes you'll hear about someone needing a bone marrow transplant because there are certain cancers that you can have in the bone marrow. So that's a very prolonged surgery and recovery time for both the person who's having the marrow transplant and the person who is donating bone marrow. When the red blood cells are produced and released, before they're released, the nuclei is removed, and I don't know the mechanism, so don't ask me that. That's more biology than I need to know. But they're a cell without a nucleus, right? That means they can't replicate. So they have a finite lifespan. They float around in the bloodstream doing their job. They can't repair themselves. They can't replicate themselves. So eventually they die off. They have about 12 to 16 weeks lifespan. And then the iron from the hemoglobin is reabsorbed to make more red blood cells. So usually the production of red blood cells and the destruction of red blood cells is relatively well balanced. If it isn't, then that again is indicating a problem. So if your red blood cell count is low, then there could be an issue. Okay. So the red blood cells are floating floating around in a plasma substance, right? So a watery, it's 90% water. And it's got the red blood cells, it's got white blood cells, it's got platelets. We've got the fatty acids floating around there, right? So the plasma volume, when we start training, if we do anything that's relatively intense, in an acute situation, so on the day or over a couple of days, we see an increase in plasma volume over time, but on the day, we see a reduction in plasma volume, right? Which sounds odd, right? You would think, why would I get a reduction in plasma volume when I'm out for my 10-mile run, right? So it's a little, at least for me, I find this, it's not, I have to really think it through. It doesn't make immediate sense to me. But what happens is, by reducing the plasma volume, the net effect is that you increase the number of red blood cells per unit volume of blood, which ends up being beneficial for aerobic work. So it's like reducing a sauce, right, on the stove. If I reduce the sauce down, I evaporate some of the liquid off, then I've got more of the flavor in what's left. Same idea here. If I reduce the plasma volume, but I've got the same number of red blood cells still circulating around, then I have essentially got more red blood cells per piece of plasma. Right? So if you go out on a particularly hot day, right, hot or humid, and you do a long training session of aerobic work, then you can see decreases of up to 10 to 20% in your plasma volume. Okay? So that means that when you have finished training, there's a lot of rehydration to do there to bring your plasma volume back. Okay? If we're weight training, not aerobic training, then we also are going to see decreases of up to 20%. Right? If we're training for long enough in a hot enough environment, then we're also going to lose plasma volume because of sweat loss. So it's really important to maintain hydration as best you can during this time. Now, that's an acute picture, right, on the day that you're training. So what happens chronically? All right. So the chronic effect of long-term aerobic work, right, the adaptation to that continual aerobic training, is that we see plasma volume increases of up to 20%, right? So again, that's a benefit. I get more plasma volume over time. That impacts my cardiac output because it impacts stroke volume and it impacts end diastolic volume. All right, if I've got more blood volume moving around the system, then end diastolic volume is larger, which means end systolic volume, stroke volume is larger, and if stroke volume is larger, remember we have a stroke volume heart rate relationship for cardiac output, and cardiac output is impacted as well. also means you're better at temperature regulation. Okay. With resistance work, it doesn't seem like we get that adaptation. Right? So the increase in plasma volume is an aerobic adaptation, not a resistance training adaptation. Okay. If you look at this table, and it's not going to be 5.1 in our new book, let me find it for you. It's 6.1 and it's on page 172. Okay. These are the changes we see at rest. So that's the health measure, right? What's happening at rest if you do this type of physical activity. So it's a really useful table, I think, because it directly compares your endurance, your aerobic work with your resistance work. Okay? So I think it's a very useful table here. Left ventricular end diastolic volume is increased with aerobic work. Right? So that activates that Frank-Starling mechanism because we get that stretch on the wall which responds with a stronger contraction, which increases stroke volume and decreases resting heart rate. Okay. Resting heart rate is a good indicator of health and cardiovascular health. But we don't see that same change if we do just resistance work. So one of the reasons why the physical activity log is geared around endurance aerobic work, right? It doesn't have to be training, but what is the amount of aerobic work that you're doing during the week, whether it's housework, whether it's shopping, whether it's walking the dog, right? Because it's the aerobic work that can positively impact your long-term cardiovascular health. Right. So we've got a very easy comparison chart there. Right. Remember that we don't have to change resting Q. So my cardiac output at rest does not have to change. So when we see an increase in stroke volume, that's going to lead to a decrease in heart rate because the cardiac output has to stay the same. Okay. Questions? Okay. All right, so what happens in the cardiovascular system when we're being physically active? All right, so the first thing that the chapter talks about is oxygen delivery to the tissue, right? What's the change in oxygen delivery and how does that occur? Right? So we have this term which looks a little overwhelming when you just look at the words, okay? Arterial venous oxygen difference. It's much easier to say AVO2 difference, right? As long as you remember what the A and the V stand for. What it's saying with these big long words is exactly that. What's the difference in oxygen saturation in the vein versus the artery. Right? So how much oxygen is coming in via the arterial system to the tissue of interest, in our case muscles, and what's the oxygen level in the venous system leaving the muscles, taking the blood back to the heart. Okay. At rest, on average, we have about 5 milliliters of oxygen per 100 mils of blood. Right. During exercise, that AVO2 difference is about 15 mils. Right? That means that they were taking out more oxygen. Does that make sense? Right? My AVO2 difference at rest is 5, and my AVO2 difference during exercise can be 15. Then that means I'm removing more oxygen during exercise. The difference between the artery and the vein increases. So, if we look at the resting picture, again, I always think it's easier to do it in pictures, and they have some very nice diagrams. Do these come from this book? I think I might have got these from a different book. Look here. Yes. I like the pictures though, they help out my little brain. So, in the artery, bringing blood to the muscle from the heart. Okay? At rest, about 20 milliliters of oxygen. In the vein, leaving the muscle, taking the blood back to the heart, we see 15 milliliters of oxygen. So between point A and point B, we lost 5 milliliters of oxygen. Right? So somehow that 5 milliliters of oxygen has left the bloodstream in the capillary and transferred into the muscle tissue. Okay? Then I go and exercise. And in this case, it's quite dramatic, I'm working quite hard. Okay? So the oxygen saturation in the artery can't change on that day. The only way that can change is if there are more red blood cells and more hemoglobin, which is a training effect over time if you're at altitude. Right? So I've got the same 20 in my artery that I had at rest. Right? But now when I look at the oxygen level in the vein, I now have 5 instead of 15. So in this case, I transferred 15 milliliters of oxygen out of the blood in the capillaries into the muscle tissue. AVO2 difference. The larger the number for AVO2 difference, the more oxygen left the bloodstream and transferred into a tissue. Make sense? So oxygen delivery as an entity, right? As a concept, if I'm dumping off oxygen out of the bloodstream into the tissue, is going to be calculated by how much blood is flowing through the capillary network around the muscle tissue and the AVO2 difference, how much of the oxygen is leaving the bloodstream and getting into the muscle tissue. Right? Oxygen delivery is blood flow times AVO2 difference. Right? It's called the Fick equation. Don't worry if you can't remember what it's called. If someone asks you, you can always look it up. Okay? But it's a well-known equation. You'll see that term, Fick equation, all the time. Right? So, oxygen delivery is another term for oxygen consumption, which we know as VO2. Okay? And blood flow is equal to cardiac output. So now we have a measure for VO2 that is cardiac output multiplied by AVO2 difference. And then you can swap out the Q and put heart rate times stroke volume. Right? Don't worry too much about this last piece. The biology, it would be more applicable for the biology students than it is for the HPE students. You can use this concept, this principle, either calculate it for the body as a whole, or you can do a local calculation for a particular circulation in a particular area. Okay? But that's way outside the HPE need to understand this idea. So if we look at this, it means that if I increase Q, right, or I increase AVO2 difference, I'm going to increase oxygen delivery or oxygen consumption. Does that make sense? So now we have an understanding of part of the mechanism for increasing VO2, right? I can increase Q, which we know happens with training, and I can increase AVO2 difference, which happens when I exercise, assuming my capillary network and everything is working healthfully, right? The other way we can increase Q to a particular muscle is by redirecting blood flow away from a different tissue, right? So we can redirect blood flow away from the stomach to active muscle tissue, and that would increase cardiac output to that muscle tissue. It's one of the reasons why it's important not to eat a big meal and then go exercise, because then you redirect the blood flow away from your stomach and you've got all this food sitting there, and that feels very uncomfortable. Okay, we're going to stop there. I've got just a couple more slides to finish in this chapter, and then we will start chapter 7. So today's Monday, so Wednesday we'll finish off the last couple of these slides. We will start chapter 7, which is the respiratory system. Okay, so then once we've finished how we move oxygen around the body, then we'll look at how do we get oxygen into the bloodstream in the first place. All right? Any questions? Have a look over it, all right? Because we kind of inadvertently introduced a little bit of baby math in here. You've got to make sure that you've got everything straight in your brain and you've got the math going in the right direction for the information to make sense. Okay? So take a little bit of time before Wednesday to review so that if you have any questions, we could do those first before we carry on with the last couple of slides. Okay?